Welcome to Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer. This is medical oncologist Dr. Neil Love. On February 26 at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Terence Friedlander from the Helen Diller Family Comprehensive Cancer Center in San Francisco, and faculty members Dr. Matt Galsky from the Tisch Cancer Institute in New York City, Dr. Andrea Necchi from the IRCCS San Raffaele Hospital in Milan, Italy, and Dr. Shilpa Gupta from the Tulsa Cancer Institute in Cleveland, Ohio. Included in the meeting were a series of pre-recorded video case presentations by Dr. Elizabeth Plimick from the Fox Chase Cancer Center in Philadelphia and Professor Thomas Powles from the Barts Cancer Institute in London, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with Dr. Plimick. The Phase 3 Keynote 905 EV303 study of neoadjuvant enfortumab vedotin plus pembrolizumab in cisplatin-ineligible patients with muscle-invasive bladder cancer presented at ESMO, and the Phase 3 Keynote B15 EV304 trial of EV-Pembro in cisplatin-eligible patients being presented tomorrow morning at this conference are rapidly shifting the treatment landscape for localized bladder cancer, as evidenced by Dr. Plimick's clinic the day I spoke with her.
I met a patient just today who came to my clinic with a diagnosis of non-muscle invasive bladder cancer starting about a year ago. He actually elected not to go through with BCG and was monitored with repeat TURBTs. 2 more showed non-muscle invasive disease, but most recently, the biopsies showed muscle invasive disease, no lymphovascular invasion. Imaging showed mild hydronephrosis, no evidence of metastatic disease. This patient was 80 years old. He was cisplatin eligible. No major medical comorbidities other than hyperlipidemia and obstructive sleep apnea. I recommended, even though he's cisplatin eligible, enfortumab vedotin with pembrolizumab. We talked about cystectomy versus treatment on our bladder preservation clinical trial, where patients with a clinical complete response can avoid cystectomy and go on to active surveillance. After a long discussion and his stated preference to keep his bladder if possible and to not go through a big surgery at the age of 80, he enrolled in the clinical trial. So I'm curious, what would you have recommended to this gentleman if he were in your clinic? Here in our practice, we've started using EVP as neoadjuvant therapy for cisplatin-ineligible patients since the ESMO presentation, but truly also for cis-eligible patients, we're still using it. I'm curious, what's your practice with EVP? I actually find in my practice giving the 3 cycles of EVP in the neoadjuvant setting is easier in many ways to get through. I think a lot of the neuropathy doesn't evolve until later, so we get away without that. I'm curious if your practice reflects that or not.
Great. So also a lot to unpack here. So we have an 80-year-old patient who develops NMIBC after having refused a lot of the therapies we just talked about for NMIBC, for non-muscle invasive, and now wants to avoid cystectomy, which is very reasonable considering the morbidity of cystectomy. So EVP is available as of today for patients who are cisplatin ineligible. We've already heard from Dr. Gupta about a press release and the data that Dr. Galsky is going to present tomorrow for cisplatin eligible patients for EVP. That's a positive study. Have you, let me ask you, Dr. Gupta, have you been integrating EVP for cisplatin eligible patients already, or are you waiting for tomorrow before you'll
I am waiting for tomorrow.
Interesting. Can you say more?
If the patient is refusing chemotherapy, then yeah, we are.
Was it just a feeling that we didn't have good data yet on the value of EVP in the cisplatin eligible group?
I think just being a purist, waiting for the data, because we do have options for these patients. There's gemcitabine, and also we had a clinical trial also where they were getting EV-Pembro as a perioperative with the vaccine study. So we had options.
Okay. And Matt, so you have had a large role in the EV304 trial. Were you using that regimen off trial in a patient, for example, like this?
Yeah, I would consider it, and I have. I think Dr. Gupta's response is obviously quite appropriate. Being a purist, you'd wait for the data. We have informed patients who come in and want this treatment after having heard about the ESMO data, and I think it's reasonable to discuss it, particularly because that trial included patients who declined cisplatin-based therapy as well.
Do you think there's an ideal patient who should get EVP? We have data now for cisplatin ineligible MIBC. Tomorrow we're going to hear about the data for cisplatin eligible. Is there a biomarker? Is there someone, some way we can determine who might benefit from platinum? For example, variant histology. Do you find that there's a rationale to maybe avoid EV and still give them platinum? Or are there other subgroups or types of bladder cancer that you have more sort of thoughts about, concerns about?
Yeah, I mean, it's the patients with variant histologies that I scratch my head about the most, and there's been a number of publications looking at nectin expression either at the gene expression level or at the protein level, recognizing that the studies looking at it at the protein level aren't necessarily using the proprietary assays that have been used in the clinical development program in patients with variant histology. And it's a little bit across the board, but some of the variants, there's a high proportion of patients with no expression. And so then you get a little bit worried about whether or not that's the right choice. But otherwise, I think it's probably the right choice in most patients.
Okay, so you give it to most folks. Okay.
If I may add?
Yeah, please.
Very, very briefly. It depends on also on the radical cystectomy suitability in this patient population. And things have changed substantially, besides the patient desire, but in most of the urology departments, consideration towards radical cystectomy suitability has changed substantially from the urology side. For example, a patient like this will never be operated on my side, will never be operated, because it is high risk of developing side effects, sure, potentially deadly surgical sequelae. So I would consider personally this patient population as being the best candidate ideally for chemoradiation or radiotherapy alone.
Right. So chemoradiation is an option we haven't really talked about a lot. And I agree with you. I think that's an option. Now, Matt, you led a very important study looking at preserving the bladder in which patients got neoadjuvant platinum and a PD-1 inhibitor. And then if they were in a strict clinical CR, they were allowed to keep their bladders and be monitored closely. And there was just a recent update. Do you think that an EVP is, first of all, tolerable, as the question here asks? And then do you think there's a role for giving EVP and then monitoring patients very closely, as that was done in this Hoosier trial, and allowing them to keep the bladder, especially in someone who's 80 years old and may have competing comorbidities?
So that's the trial that this patient was enrolled on, was EVP with potential for no cystectomy in patients who have a clinical complete response. And I think it's reasonable to do right now in the context of a clinical trial. I don't think this is ready for prime time. This is a departure from standard treatment and has a large amount of risk involved in not doing this right. And so I think we need more data before it's ready for prime time. But I think that's where the field's headed.
Right. And just to be clear, a strict clinical CR involved, correct me if I'm wrong, MRI, cell-free DNA, cystoscopy. Were there other measures that were used?
Cytology, imaging, cystoscopy, biopsy of any visible tumor, or blind biopsies in a template if there was no visible tumor.
Right. So we have to be careful about just giving systemic therapy and not addressing the bladder either with surgery or chemoradiation. In the last 5 seconds, do you think this is a tolerable regimen for an 80-year-old man, EVP?
I think it absolutely can be a tolerable regimen, but like most of our systemic therapy regimens, there's a lot of heterogeneity. So some people fly through it and some people don't.
Right. So it's very individualized. Okay, let's move on to the conversation with Dr. Pauls.
The next patient, presented by Professor Pauls, is a man in his late 70s with BCG refractory CIS.
We gave him induction and maintenance BCG, and during the maintenance BCG, he relapsed with more carcinoma in situ. And so there has been a huge expansion in novel therapies in this space, in the CIS refractory disease. And that has been largely driven by the FDA's willingness to approve drugs off single-arm trials with only 100 patients. And Sunrise-1 was a great example of that, where we gave TAR-200, an intravesical pretzel-like device. It slowly releases gemcitabine over a period of time. We've used a lot of this drug in our practice within the context of clinical trials. The device is novel, not the drug. I think it's fair to say that this intravesical device has probably superseded some of the other therapies which are being explored in BCG refractory carcinoma in situ. There's a Sunrise-3 study, which is looking not at BCG refractory carcinoma in situ, but frontline high-risk disease. And this trial, for me, is the Jupiter of trials, because if it was positive, it would be a landmark change to a huge patient population. Because unlike the immune checkpoint inhibition, which is associated with 15% life-changing toxicity, hypothyroidism, long-term diarrhea, arthritis, fatigue, these drugs just have local toxicity.
Any questions for the faculty?
With so many treatments available of single-arm trial, is there a preferred treatment? Do they agree with me that if Sunrise-3 was positive, that would be much more transformative than the current situation, which I think is treatment modifying, but not treatments transformative?
Okay, so also a lot to unpack here, and I think a very interesting case. A 70-year-old man who has BCG refractory carcinoma in situ, so non-muscle invasive bladder cancer. And I think, Dr. Necchi, this really gets to the very heart of your talk. You said earlier that the standard of care for BCG refractory disease is to remove the bladder. Now we have, at least in the US, we have TAR-200 available for exactly this patient. Do you have any concerns about giving TAR-200? Would you give it to everybody, or are there patients you might avoid giving it to? How do you think about that?
Well, with regards to tolerability, at least recorded within a clinical trial, the data are very favorable in supporting the use of TAR-200 in this patient population. In real world, there is an accumulating amount of data indicating that docetaxel and gemcitabine, so intravesical chemotherapy, could be another option. The point is that the use of intravesical gemdosi is much less frequently adopted outside of the US, very infrequently used in most of the European countries, for example. But that could be an option. But yes, the TAR-200, as we currently stand, is best position. And second, we have data for cretostimogene that are also quite compelling, but again, generated in a clinical trial context that was primarily focused or exclusively focused on the United States. So for cretostimogene, we need a bit more expanded access, a bit more heterogeneous patient population with regards to geographical variability to confirm the initial findings.
And so to follow on that, I think, obviously we're hearing that there's value to TAR-200. We need more data there. Tom talked about the Sunrise-3, which is looking at TAR-200 in the frontline setting, and actually just the same way that enfortumab, vedotin, and pembrolizumab is displacing cisplatin as our go-to regimen, as our frontline regimen. Do you think there's a real possibility that TAR-200 could replace BCG, and what are the pros and cons of that? Obviously, if it looks much better, that's great. What if the data looks similar? How would you think about this? How would you counsel the patient, also recognizing there's a major BCG shortage worldwide?
Yes, this is the major point. I suspect also that from the urologist standpoint, even though they seem to be quite happy in using BCG, whenever they got any alternative therapy that is effective or more effective than BCG, they will jump directly in this direction, as we did for standard cisplatin-based chemotherapy in the neoadjuvant setting. Whenever we had any alternative option, all of us jumped into this direction. So it depends, as you said, on the magnitude of effect for sure, and the trial should be clearly positive. with regards to the primary endpoint and maybe key secondary endpoints. The BCG is hard to beat, has demonstrated to be very hard to beat in clinical trials. The performance is quite good for BCG. It reminds me of a situation in the NMIBC, which is similar for chemoradiation. So very hard to beat comparator because in clinical trials the performance is quite good. So let's see, but for sure I agree with the colleagues that positivity of Sunrise-3 trial will make a huge difference in the way we sequence intravesical therapies in patients with NMIBC.
Okay, so much more to come in the frontline setting, and I think it sounds like we're going to need to hear about the efficacy. Maybe toxicity is going to be similar between BCG and TAR-200, perhaps. Dr. Gupta, so FGFR-altered bladder cancer is one of the only truly biomarker-defined diseases we have. There was data that Dr. Necchi showed us about giving oral erdafitinib that seemed to be fairly, toxic in terms of side effects. What do you think about TAR-210? And what I'd love to know is, like, if you have a patient who has an FGFR mutation, do we think TAR-210 is a better drug than TAR-200? Are we actually achieving something by looking for this biomarker and treating, or is it too early to say?
Yeah, I think, FGFR is the only biomarker right now which is truly, we know, that drives the cancers, and we have a therapy for it. So I think oral erdafitinib is definitely very, very toxic, especially in patients with this early stage, and that's why the study was stopped early. And I think the TAR-210 data is really compelling. You're getting the efficacy from the FGFR inhibitor without the systemic toxicity. It's best of both the worlds, in my opinion, and definitely would go for that.
So it seems like it may be an option in the future. I want to emphasize when Dr. Necchi showed the PK, there's like a 2 log-fold less, like 100-fold less erdafitinib being absorbed when we give TAR-210. I guess open up to the panel. Do we think that TAR-200 is going to be inferior in an FGFR-positive population? We don't know. Is there a rationale to sort of develop both drugs? I mean, clearly they are being developed, but how do you think about that? Go ahead.
I just want to add that, in all the other studies with TAR-200, we really don't know what % of patients were FGFR-altered tumors. So it would be good to look at that retrospectively and see how they did and make that decision.
Agreed. Any other comments about, other therapies that we should be putting into this patient population who has sort of high-risk non-muscle invasive, and any comparative efficacy that we have?
Well, we do have the data from nadofaragene that are pretty much consistent with the data obtained with pembro monotherapy. It's a way of achieving similar results by delivering intravesically a drug instead of systemic therapy. So clearly, results that stands as a second option in theory after the results shown with the TAR-200 and cretostimogene that are at the forefront of the development with regards to CR and maintain CR. There could be additional data that soon the data will be presented with newer systemic immune therapy combinations showing that there is no signal for enrichment in CR, but we do have much more toxicity events in this patient population. So the struggle is again in identifying possible new combination therapies that are aimed to minimize a little bit the toxicity that we can provide to the patients with systemic therapies. It's a challenge, but today the primary focus is on monotherapy as intravesical therapy.
Intravesical, right. So this is a disease confined to the bladder. We should probably be giving diseases into the bladder and not exposing patients to all the risk of systemic therapies. At least that's the trial data so far. Or
maybe TAR-200 or gemcitabine and erdafitinib combined into the unique system into the bladder.
Right.
Technology may allow us in the near future to provide multiple therapies the same way.
Right. So there's really a lot of super interesting options. I think it's a great time to be in this field to have so many options.
Subsequent to the recording of this program, the FDA approved durvalumab in combination with BCG for the treatment of adult patients with BCG-naive, high-risk, non-muscle-invasive bladder cancer. The FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. The FDA also approved adjuvant atezolizumab for adult patients with muscle-invasive bladder cancer with MRD-positive ctDNA after cystectomy. Please check out the official prescribing information for more. This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed, so check out the package inserts for more. Special thanks to the faculty, and thank you for tuning in. This is Dr. Neil Love for Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer.